This conference will now be recorded.
All right. So now we will be discussing about ovulatory disorders, all three WHO categories of the same. And we will also be discussing about artificial reproductive techniques and how the questions around that are phrased. Okay. And I'll emphasize what is important from your exam perspective. But also have a couple of the TOG articles which will contain your single best answers, as I mentioned before, which we can do directly in the group as well at a later point in time. Okay, so I'm not going to spend too much time in those TOG articles, although we have prepared, material for the same. So, sorry. All right, so this is your list of the different dog articles. Now, what I have compiled for you here is resources from these articles itself. Okay, so you don't have to worry, they're just, reordered in a fashion that is easier for us to understand and to remember so that you can answer the questions in a smoother way. All right, so essentially, today's is more conceptual kind of a lecture so that you are able to specifically, because extended matching questions come from the different ovulatory disorders and other factual questions which come up, they will be your single best answers. So you have to target that. All right. So, coming to your ovulatory disorders, we know that there are three categories or three groups by WHO, which is group 1, group 2, group 3. And essentially, the first group, okay, everybody knows this part, but you have to remember the percentages also. They have asked this in SPAs and previously, all right. So, as a group of ovulatory disorders, hypogonadotropic hypogonadism, that is, as we had discussed the last time, your gonadotropins, which are coming from your pituitary, okay, are deficient. So, either because of hypothalamic problems, wherein you're not having GnRH release from the hypothalamus, or because the pituitary dysfunction is occurring, so you don't have your FSH and LH being produced in the gonadotropes in the pituitary, and as a consequence of that, downstream you don't have any estrogen coming from the ovary. So this is typically what it is going to be like. Okay, these comprise between 5 to 10 percentage of your ovulatory disorders. All right, we will go into detail of each of these categories. Okay, and relevant material from your talk articles will be discussed. So, in group 2, which we have the maximum number of disorders coming from, is your normogonadotropic anovulation, which is most famously, everybody knows this, is PCOS. Okay, so here you have nothing wrong with your hypothalamus or the pituitary, but essentially it can be because of an imbalance. All right. So despite your FSH LH not being too low, not being too high, okay, it can be disordered in the sense that LH can be marginally high, okay, FSH as well can be marginally high, and the ratio can be altered. But you have FSH and LH essentially with a functional pituitary and a functional hypothalamus. Okay, that is what we mean. Functional pituitary and functional hypothalamus in category 2, which is 85% of the disorders. Okay, and then we also have your hypergonadotropic hypogonadism, which is the third category. Downstreams, your ovary is not functioning, so premature ovarian insufficiency for whatsoever reason. Essentially, what you will have is the ovary, despite receiving signal, is not producing estrogen. So your negative feedback is not there for the FSH, and it keeps on rising. So you have an increasing FSH, okay? Because upstreams, the hypothalamus and the pituitary, they are functioning fine. All right. So this is the concept of the three WHO categories of an ovulation. Now, this is the least amount, which is 5% of ovulatory disorders. Do not confuse this with the incidence of premature ovarian insufficiency in the general population, which is 1%. Okay, so it is 5% of ovulatory dysfunction problems. All right, so now because we don't have our egg getting released, we are having a bit of a difficulty conceiving. So now, although I have given the brief outline of treatment here, we will go into details of the same. So I'm not covering this outline here right away. So firstly, what the NICE guideline says about ovulation disorders is that you have to take your history, as we have discussed previously in the first session. So if you are having regular monthly menstrual cycles, what that means is that 90 to 95% of these women are ovulating. Okay, it's not a 100%, but 90 to 95 chunk of them will be ovulating. All right, this figure comes from a two different TOG articles as well. So now, what you must do after taking this history is reassure them that they are likely to be ovulating. But once they have crossed that 12-month interval, and despite the regular cycles a woman is getting, you want to conclude whether they are ovulating in fact or not. And you have to prove this. All right. You have your EMQs wherein they will tell you, okay, regular cycles are there. Depending on the time interval, there can be like they've come at 8 months, the answer changes to reassure. Whereas if they have come at 12 months of trying, but regular cycles all good on history, all right, your answer is going to change to you have to do serum progesterone day 21 because they are having a 28-day cycle. Now, a third answer can be they might provide you with a third scenario in the same EMQ, wherein they'll give you somebody with a 35 to 40-day cycle, okay, and they are having irregular. So they might ask you, your option changes from day 21 to day 28. Is that clear? Is that clear why the answer changes according to what they've been asking? Dr. Nero, Dr. Kayal, hello. Yeah. All right. So, if you have a longer cycle, which is around 35 days, what you have to do is subtract from whatever the length of the cycle they have given you, 7 days before that, you will do your serum progesterone level. The reason is you want it mid luteal phase. So, you expect that ovulation occurs 14 days before your next period, and you want it in the middle of that. Okay, so 7 days after your ovulation expected. All right, so if you are expecting ovulation on day 21, you will do it on day 28 in a longer cycle. In any other woman with a regular 28-day cycle, you are having ovulation on day 14, and thereby you are doing it on day 21. Okay, all right, clear so far? Okay, you guys can interrupt if something needs to be repeated, okay, instead of me like taking pauses multiple times and asking. All right, now, in case of irregular cycles, now you find that the progesterone is low. All right, what do? You have to repeat it weekly. Every 7 days, you will do it after your 28 days. So you will do it 35 days and then you will do it thereafter. Okay, every weekly till such time that the woman gets her menses. So the idea here is that you follow through expecting ovulation, maybe even if it's a longer cycle and delayed ovulation. Okay, but you are expecting ovulation, so you keep on trying and until you get your next menses. All right, that conclusively will prove that this particular cycle was anovulatory, no progesterone getting released, no corpus luteum was formed. Okay, now for prolonged irregular cycles, remember this. Okay, although you do not do in a woman with regular cycles. And then you have done day 21 progesterone, and if it has come ovulatory cycle, please do not do any further tests like TSH, prolactin, testosterone, androstenedione, none of that. All right. However, if you have concluded an ovulation regardless of length of cycle, or if you have other symptoms of say galactoria or headache, or you have thyroid related symptoms, okay, dry skin, cold intolerance, any of those, then you will do TSH, prolactin, okay, depending on what you're suspecting. And if an ovulation is there with prolonged irregular cycles, you will do all of them. Okay. So because you're investigating PCO, and cardinal to PCO investigation is ruling out other endocrinopathies as well. Okay, because we are going to look at Rotterdam criteria soon. So you do not do basal body temperature, and other tests that we had spoken about earlier was your cervical screening test and rubella immunity, tubal patency, and semen analysis. So we had a contentious issue about doing tubal patency tests previously, and we had discussed when to do it in unexplained, when to do it when all your history is good, when to do it in cases you are using artificial intrauterine insemination. But in case of an ovulation, okay, prior to ovulation induction, please remember, you have to do your semen analysis, you have to do tubal patency. Can anybody tell me the logic behind why we are investigating these two issues earlier? Okay, in case of IUI, we said we can go ahead with IUI, but why are we not doing ovulation induction with the same principle, assuming that the tubes are patent? Um, Dr. Kyle, hello, Dr. Kyle. Okay, Dr. Anyone? Hello, hello. Am I audible? Hello, Dr. Kyle.
Yes, ma'am.
What do you think the reason could be why we are doing tubal patency tests before ovulation induction, whereas we deferred it in just insemination?
To rule out the tubal block.
Yes, but there is no history, there's no positive history. You're not suspecting a tubal block, but yet you are doing it pre-ovulation induction. And prior to IUI, where there was no ovulatory disorder, you didn't mind. You did 3 cycles and then you were going to do tubal patency test. Why?
And
Okay, so the answer to this question is that you have a limited number of goes with ovulation induction. You can't use clomiphene citrate beyond a certain number of cycles. All right, you got 6 cycles. Now, in those 6 cycles, if you're not able to achieve a pregnancy, the next answer becomes that you go for IVF. Because if you've achieved ovulation, mind you, for 6 cycles and you're not conceiving, that means it is now becoming sort of in the category of egg is there, sperm is there, everything is there. However, she is not conceived. Now, if at the end of this you start investigating her tubes and you find that there was a block, you have wasted,
yes,
okay, whatever opportunity for ovulation induction we had. We can't go on giving CC. All right. That is the reason why we want to invest. Okay, we'll tell the reason why as well. The reason is because clomiphene citrate was and is hypothesized or connected to the risk of cancer, not ovarian malignancy outright, but borderline ovarian tumors. Okay,
Okay.
because of this, there was some evidence with regards to BOTs. We have to be careful with the number of cycles that we can use for CC. Okay, clomiphene citrate. So the other investigations that we do, as discussed before, is you do a testosterone. Okay, the normal value of this is like 2.8. Okay, and beyond which point of time it would be high androgens. Okay, and then you have your free androgen index as well. Okay, and if it is more than 5, it is abnormal, and you can have high TSH raised prolactin. These are the other tests that you can get abnormal in cases where you are having WHO category 2, which is your PCO. Okay, so we are going deeper now into category 2 first, and then we will go to category 1 and then 3. Okay, so if the testosterone is very very high, then there come three particular underlying disorders which can cause PCOS, which you need to rule out. All right, which are late onset CAH, Cushing syndrome, and androgen secreting tumors. Okay, now this has been asked only in the form of single best answers before. All right. So, if your androgens are high, you start suspecting underlying disorders, which are these three. And to differentiate these three, I have given in the next column what are the tests that we can use. All right. So, for late onset CAH, we will do a 17 hydroxyprogesterone value. Whereas for Cushing's, it is 24-hour urinary free cortisol, which will be high. And in case of androgen secreting tumors, we obviously have serum androgens, the DHEAS, and androstenedione and free testosterone for any tumors. Okay. And additionally, we have imaging investigations which will allow us to identify adrenal or ovarian CT, so adrenal or ovarian tumors, as well as MRIs, MRI brain, okay, which can be done. Okay, and MRI brain is another investigation that we will do in your raised serum prolactin as well. So remember that further evaluation, if suspecting any of these three disorders, will be done by these tests according to whatever disorder is there. Now, how will you be asked the question? It will be in reverse. So they will give you a particular scenario, maybe of hyperandrogenism and PCO sounding like, but then they will give you lots of hirsutism and they might say 17 hydroxyprogesterone is there. What is the diagnosis? Okay, that way. Okay, so reverse engineer this particular thing. So we can have other things like hypothyroidism and raised prolactin, which are also underlying causes for anovulation category 2. So in these situations, what you must do is do a TSH value, and if that is the range, then you do a free T4. Okay, you would need to treat the hypothyroidism first before going for ovulation induction. And you have to remember that about 70% of the cases of subclinical hypothyroidism, women may not ovulate. Okay, so they might not have other symptoms, etc., of thyroid disorders, but an ovulation can be the way that it is picked up, but it is not extremely common in ovulating women. Okay, so you do it only if there is an ovulation. Similarly, you do prolactin values only if there is an ovulation or other symptoms of hyperprolactinemia. Okay, not on a general basis. You will not do it routinely. Okay, so far clear? Clear, guys? Anybody wants any repetition? One, two, three. Okay, all right. So now we come to what NICE guidelines says in brief about these things before going into details of TOG articles. So in group 1, we have hypothalamic causes most of the time. So it just simply says that you need to increase the body weight. So in hypothalamic causes, essentially you will have things like anorexia nervosa or starvation, okay, very, very low BMI. So if the BMI for conceiving ideally should be between 19 to 25, which is normal, okay, and so here you want to advise increase if it is less than 90. Hmm? Secondly, if they are exercising a lot or too much, you will ask them to moderate their exercise. All right. And then the third thing is to offer pulsatile GnRH or gonadotropics. Okay, GnRH from what is the hypothalamus produces. All right. So this is what we need to give, or we give them directly HMG, that is a mixture of FSH and LH. Okay, remember your options might comprise just FSH, recombinant FSH and LH, or LH, or it will comprise of pulsatile GnRH. Now, if I give you all of these options and I say that she's in WHO category 1, hypogonadotropic hypogonadism, which of the following will you choose? Okay, so you have pulsatile GnRH and you have HMG and you have recombinant FSH, and fourth option is recombinant LH. Fifth, I cannot imagine for you, but if I were to ask you this question, what would you choose? Dr. Pallavi. Dr. Pallavi?
Yes, ma'am.
Yes, what would you go for?
Ma'am, HMG, because it's a combination of FHSLH.
Okay, why not pulsatile GnRH? That will also
Mm,
produce, it will signal production of FSHLH, right?
yeah.
Yes, but why not? Your answer is right. I just want you to know why. Why the thing is. See, HMG, okay, and recombinant FSH LH combinations, both of these are cheaper, okay,
Hmm.
and more readily
Yeah,
available, accessible than
yeah.
pulsatile GnRH. Although both are an option in your NICE guideline, and it says that you can offer both, you have to remember
Hmm.
that HMG, if given, would be a better option. Okay.
Okay. Yeah.
Yeah. So then you have your category two, which is again as per NICE. It says clomiphene or metformin or combination of the above. But we will see how your answers change as per scenarios which are provided. Okay. So the first thing in all of these, remember that if your option of weight gain in category 1 is provided to you, or group 1 is provided, please choose weight gain. Don't choose GnRH and other like ovulation induction. The answer, you have a tendency to jump to thinking, oh, it is this, so we are going to do put HMG for them. We're going to stimulate. Similar thing happens with PCO. If the option of anybody with BMI more than 30 is provided to you, okay, and the age group, it will typically be in a younger woman. Okay, they'll not give you somebody who is like 38, 39, BMI 30, because that becomes a very debatable issue at that age, whether you want to do induction or you want to advise lifestyle measures first. Okay, but we will see what British Fertility Society has to say with regards to the BMI cutoff ranges for ovulation induction as well. Okay. At the same time, remember, first option would be your weight loss measures, and then whatever other things that you have to choose from the options. Look at the age of the patient, BMI of the patient, and your options carefully. Okay, read it completely before choosing your answer. So, how do we diagnose PCOS? We need the Rotterdam criteria. Now, there has been a little modification of the Rotterdam criteria, but you don't have to worry about the same because we are going with this one, okay, as of now. All right. And I will also do a recording on the change which has come about and why certain things are different in the new PCO, international PCO guideline. But for now, the questions which have been asked and still the answers, they pretty much remain the same. You have to know, they will ask you, they will confuse you with combinations of options where it will be very, very tempting to pick something wherein they've given you PCO morphology, whereas they'll give you another value like AMH has been high, okay, something on those lines. And then you will feel like, okay, since the ultrasound is provided, it becomes a better option. Remember that if you just have your history of hirsutism, and if I give you history of anovulation, that is absent or infrequent menses, okay, oligomenorrhea or amenorrhea, and if I tell you that she has lots of acne, lots of hirsutism, these two are enough. Generally, these two would be enough, but you need to have either clinical. So, either we have had hirsutism acne, or we have proven biochemically that there is increased androgens. So, with testosterone or raised free androgen index, what we spoke about, no more than 5 it can be. So, you can either have a biochemical or a clinical thing of hyperandrogenism. You can just have oligomenorrhea or anovulation, which may not even be proved on ultrasound or your 21 day progesterone. Okay. And the third criteria, you need two out of these three. The third criteria being the morphology on the scan. So, scan is not a must to make a diagnosis. Okay. So now on scan, what is the morphology? Either you need a volume of the ovary which is large, like it is a big enlarged ovary more than 10 ml, or you have more than equal to 12 follicles in either of the ovary. Okay, the size of the follicle, immature follicles, it is considered between 2 to 9 millimeters in diameter. Okay, so you can have either or both of these situations happen. Okay, so we require these, any of the two of them. All right, two of these criteria to make a diagnosis of PCO. Now, of course, we know that you need to rule out other disorders like your thyroid, hyperprolactinemia, non-classical CAH, androgen secreting tumors. Okay, hmm? Which we have spoken about. We knew what investigations to do here in this very slide. Hmm? Pre-induction, so far clear, diagnosis is clear, how to rule out other disorders is clear, right? Okay.
Yes,
Okay.
ma'am.
Yes, okay, great. So now we move on to pre-ovulation induction. What are the key steps that you need to do? Now, I just mentioned type 1 here, but we are discussing more in terms of type 2 PCO. Type 1, of course, you have to gain weight. This is what I told you for your SPAs. But in type 2, first answer would be lose weight if the BMI is high. Okay. Now, if the BMI is normal, however, you can choose the ovulation induction directly. Okay, direct option you can choose. Correct any underlying endocrine disorders before moving on to the main thing, that is induction of ovulation. And you have to, of course, do your tubal patency and your semen analysis. Okay, so that's a write up of the same tables which I had provided for you. Now, this is in given in two of your TOG articles as well as your British Fertility Association guideline. Okay, about the target BMI ranges. What does it say? It says that you defer induction, meaning you do not do ovulation induction if BMI is more than 35. 35 is the overall figure you have to remember. However, if the woman is less than 37 years of age, what it says is, you if you've got the time for it, you should target a BMI of 30. Okay, so although you can induce between 30 to 35, and you should absolutely, what the guidelines says is you do not do it more than 35. Ask them to lose weight if they are category 2 or above. Okay, they are category 2 or above. You ask them obesity. Okay, category 2 or above obesity. Ask them to reduce weight first because it's unsafe to get pregnant with ovulation induction at that BMI. However, if you've got more time, because you've got to balance this, all right. So if you've got more time, you would ideally want it to be not even category 1. You want it to be, all right, pre-obese. All right, you want it to be pre-obese. Okay, that is overweight. Hmm? So now, lifestyle modification as discussed before. Is this clear? Are all these figures clear to you about the target BMI?
Yes, ma'am.
Yeah, okay. So the clinical benefits of weight loss can be that even if you ask them to lose between 5 to 10% of the reduction in body weight, it translates into a 30% reduction in the visceral fat, which improves your insulin resistance and also restores the ovulation in majority of many of the cases. Okay. All right. And when you are doing ovulation induction, you will get a better response. That is the reason why we do lifestyle first. Okay. Moving on. You have to understand that the advice given per the TOG articles, this is not asked so much, so I'll quickly just go through over it. It's important for part 3 more so, because calorie restriction is what you do and try to have an energy deficit of 500 to 1000 to lose anywhere between half to 1 kg per week. That's a target. And daily activity minimum recommendation is to have 30 minutes of exercise like a brisk walk every day, but ideally should be between 60 to 90 minutes per day in a combination of the exercises. Bariatric surgery is only considered if the BMI is more than 40 without with or without comorbidities, or if it is more than 35 with significant comorbidities like diabetes, hypertension, obstructive sleep apnea, all of that. Okay? Mm-hmm. All right.
Yes, ma'am.
Not super important for part 2, but yeah, going through. Next, you have to understand about your ovulation induction regimens, and quite commonly, for whatsoever reason, they ask about success rates of these. So please pay attention when we are going through that. All right. What you do is you put a chromiphene citrate starting from day 2 of the menstrual cycle, anywhere between day 2 to day 5, but typically our answer is going to be day 2. Starting dose is usually 50 milligrams daily for and given for 5 days, unless you have reasons to reduce this, which to 25. So, for example, in PCO, many a times you can have a anticipation of a exuberant response, that is you have OHSS possibility. So if that is so and you think that, then you can begin at 25, but typical answer 50. Okay, then what you do is, remember this, very important, to monitor the response for at least the first cycle. Okay, you have to do serial ultrasounds, transvaginal scans, in order to see the number of follicles and the size of those follicles develop. So whether your dose has worked and you continue the same, or you need to increase it. Mhm. Or there is too much response and you want to do cycle cancellation and you will do a reduced dosage next time. So this all will depend on the monitoring. Okay, at least the first cycle doesn't mean only one cycle will be monitored. Okay, means that subsequently if your response is satisfactory, you continue same dose. However, if you're changing the dosage again, you have to monitor in the subsequent cycles. Okay, and then you need to confirm ovulation. It doesn't stop at the TVS. You need to confirm ovulation with typically with a day 21 in a 28-day cycle. Okay, so because you are anticipating with CC response by day 21, you will do your day 21 progesterone as well. Okay, so if unifollicular response is achieved, continue same dose. If no response, increase it to 100. Still no response, increase the next to 150. This is the max dose that we can have. Okay, we can't have more than this. We can't go on to 200. All right. So if there's no response at 150 at all, and you have tried up to 6 cycles, what does it become? What is it called now, Dr. Kyle or Kayal? I do not know how to. Dr. Kayal,
Um,
no ovulation. You've tried up to 150 milligram per day. You've tried 3 cycles with this. Now,
mm.
what is it called?
And resistance, clomiphene resist.
Good. Okay. So this is clomiphene resistance. All right.
Mhm.
So now
Oh,
the BFS recommendations for the same are you can allow more cycles, but please remember that NICE guideline doesn't allow more than 6 cycles. Okay, NICE does not allow more than six. There's a cap on it. So the effectiveness of ovulation success, meaning that per cycle up to anywhere between 70 to 85% will ovulate, and around 15% are CC resistant. Okay, they are not going to ovulate with response to this. And however, the cumulative pregnancy rate after you have done OI for 6 cycles and you have allowed her to try and conceive with that, 60 to 70% will achieve with this itself. So it's quite a good response. 70 to 80 will ovulate, okay, per cycle. 60 to 70 in 6 cycles will conceive. Okay, important figures. The next step, if there is CC resistance, is to go for either, okay, metformin as an added thing with CC, or gonadotropin therapy, or laparoscopic ovarian relief. Okay, what will you go for first? If you have not exhausted your 6 CC cycles, okay, you are going to add metformin. Okay, now again, how do you choose between just clomiphene citrate, clomiphene with metformin, or letrozole versus gonadotropins in the situation that you provide? Now if you have been given a scenario where BMI is 21 and there is PCO diagnosed with Rotterdam, she has not undergone ovulation induction before. This is a lean PCO, right? You want to choose clomiphene citrate. You can choose your standard dose of what we have discussed now. Okay? There is not much benefit of adding metformin while the BMI is on the lower side. However, okay, if you have CC resistance, okay, as per NICE, you can add metformin later. If you've been given a scenario, you have just used plain clomiphene citrate before and it's not working out. With your max dosage, you can choose the next one to be clomiphene with metformin. Okay. Or if your BMI is more than 30, okay, if your BMI is more than 30, as the first step also, you will pick clomiphene with metformin. Is that clear? Yes?
yes, ma'am.
Hmm? Now, I give you a scenario where 6 cycles of clomiphene have already been given. Okay, patient has exhausted it. All right. They give you the progesterone levels which confirm that the progesterone levels were high. Okay, in all 6 cycles they have progesterone levels which remained high, and the woman has not conceived. Now what do you do? Yes, Pallavi?
Hmm.
LOD.
It is
Uh,
chromiphene
clomiphene?
failure.
Failure. Yes, yes, yes. It's failure. So now the answer, Dr. Amy? No. Metformin dose. Metformin dose is up to 1500 per day. Okay. So, Nero, what about letrozole first line treatment? Not so far as acceptable in your RCOG exam. Okay, not so much. Dr. Nero, is that clear? I know there's
Yes,
a
madam. Yes, madam. Clear.
So, because although the earlier guideline which was there on long-term effects of your polycystic ovaries, okay, that has been archived and it has been replaced with a link to the international PCO guidance. But at the same time, you have to remember that letrozole has not yet been licensed. For the purpose of your exams, you will not choose that particular thing. The reason why the licensing was deferred previously was there was some research which said that letrozole was teratogenic and it caused cardiac and bone deformities in the fetus. So, because of that, clomiphene remained as the predominant one in a closed group meeting which was there. One of your talk articles does also mention this particular thing. All right. So, although it's acceptable almost everywhere, please do not go for letrozole as of now as your answer. Okay. It can change very soon, but not as of now. So here we have our laparoscopic ovulation dealing. Somebody said no, 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 because you have achieved ovulation. The 21-day progesterone was high. So when you had your egg, you had your sperm for 6 months. Now they are meeting up, but and tubes are patent, right? So now they are meeting up, and somebody is not conceiving. What is this? This is failure. Okay, so now it is almost equivalent to you don't have a cause for this, right? Becoming sort of unexplained. So it is CC failure. Hmm? By that logic, we directly go for IVF. All right. Now, when you do induction, okay, and they give you value, they will not tell you somebody ovulated, not ovulated. They'll say 21st day progesterone was low, whatever the values are, less than, say, they say 10. Okay. Now, they will ask you, what is the next step? So now you know that egg never got released. So you are going to try other measures to release it. Okay. So you've exhausted 6 cycles clomiphene, but you have other measures. You are trying to get ovulation to occur, and therefore you will choose either between LOD versus GnRH. Okay. Yes, not GnRH, sorry, gonadotropins. All right. I misspoke. Gonadotropins. All right. So you do not use GnRH in category 2. You don't use GnRH in group 2, only in group 1. Right. So we have either laparoscopic ovarian drilling or we choose gonadotropins. Based on what do you decide between LOD and gonadotropins? What is the, like, depending what have they given in the question, how will you decide between LOD versus gonadotropins? Mm-hmm. For clomiphene resistance. Okay, so the first thing in clomiphene resistance we did was, if we have any remaining cycles and we have given plain clomiphene, we added metformin. Okay, first option. All right. Now we have exhausted 6 cycles of clomiphene with or without metformin. Now we've reached a point where we need to choose between gonadotropins, LOD, and how do we choose between them? Is you look at patient characteristics and wishes. Now, normally the first should be to use gonadotropins because LOD is a surgical procedure with all of its risks. All right. So you want to go for a FSH, all right? You can use plain FSH in category 2 without LH as well. But in WHO category 1, we had to use HMG, which is a combination of FSH and LH, or a recombinant FSH LH combination. All right? Why? Here we have a functioning pituitary. We can just stimulate with FSH and leave it at that once the egg is stimulated. All right? Hmm? So you can just use FSH, but if the woman is thin or if there is hypersecretion of LH on day 8 of the cycle, which the authors of the TOG article on PCO recommend. Okay, if this characteristic is given, remember ovarian drilling would be much more, in terms of response. Okay, you can go for laparoscopic ovarian drilling. All right. Hypersecretion of LH, thin woman, normal BMI. Okay. And other thing, reason could be if they've mentioned something like patient doesn't want injectables, or they will mention the patient is worried about OHSS or cannot follow up for ultrasound. In those cases, LOD. Can you tell me why? Non-follow-up, you want to prefer LOD, laparoscopic drilling.
Because
It's
for gonadotropin, when we require follicometry. If she's not following, we'll not be able to do that.
okay. Can you repeat that? Sorry.
Ma'am, when we are giving gonadotropins,
Mm-hmm.
we have to do follicometry. Follicles we have to see.
Yes, yes. Okay.
But if she's not doing the follow-up, we'll
Yeah.
not be able to do that.
Right. So laparoscopic ovarian drilling essentially reduces your chances of OHSS and of multifetal gestation. So we are not bothered about unifollicular ovulation there at all. Okay. Whereas when you are giving FSH, you want to select that only one or max your two. Okay, follicles are there. Okay, if it's more than 14 millimeters, more than two follicles, then it is a cause for cancellation. So you would not be allowing her to get pregnant in that particular cycle because it increases your chance of OHSS or multifetal gestation, right? So ovulating for 6 cycles, we discussed this. This was clomiphene failure, so we want to go for IVF. Now, other points in NICE is always offer ultrasound. We said this, okay, at least for the first cycle. And do not continue treatment more than 6 months. This is what we are following. And women prescribed with metformin should always be told about the side effects, not super important from question perspective. Okay. For resistance, now thankfully we have discussed this already. We do either LOD or we use added metformin if it was not used as first line or gonadotropins. Okay. Pulsatile GnRH in CCR. Do we use? No, you will never pick this. Okay, you will never pick. In fact, the TOG says that it's not to be used. Okay, at least NICE says it is used in research context, but generally not. Okay, so adding growth hormone previously was recommended, but no longer. It does. There is no benefit of it, and you do not use any GnRH agonist concomitantly while you're using gonadotropins. Okay, so you do not do any of these particular practices, older practices, but no longer. Okay. So, other side effects of anti-estrogens besides OHSS and multiple pregnancy is having hot flashes and reduced cervical mucus. Endometrial lining can get thinned, so pregnancy rates can be affected because of this, particularly in women where there is persistent hypersecretion of LH, meaning that you've stimulated with clomiphene citrate, but the ovary keeps producing too much of LH, and that is what results in endometrial thinning and other things. Hmm? Multiple pregnancy rates are between 2 to 13%, reasonable enough. Okay, we want to keep it less than 10%. NOHSS is between 1 to 6%, purely with clomiphene citrate. Okay, there is a risk of borderline ovarian tumors, which I mentioned earlier to you. All right. So, uh, the next thing is about the types of gonadotropins that we had, and we have discussed this briefly. All right. The FSH only preparations would be adequate enough. So either we can use urinary FSH, recombinant FSH, or HMG, which contains LH as well. Not asked so far, but just you can go through this particular one. Hmm. For gonadotropins, the multiple pregnancy rate is between 1 to 10%. Okay, as unlike with your CCs, similar category is that 2 to 13%, but it's 1 to 10% with using FSH, that is your gonadotropin. Hmm? So next, how to prevent? Our goal is to achieve monofollicular development always. So we cancel the cycle if more than two follicles are there, which are more than 14 millimeters, and we can go to the next cycle. Subsequently, can induce. Serum estradiol monitoring is not routinely recommended at all. And whenever you are using your gonadotropins, please use for OHSS, okay? Low dose step up protocol. All right. So we start with a low dose of anywhere between 25 to 50 international units per day, FSH, and then we increase it. The first dose increases only after 14 days if the ovum is not stimulated, and then subsequent increases happen only every 7 days. Okay, so it can take a long time, almost up to on an average 35 days for this particular protocol to have the egg stimulation occurring. Okay, but we want to go slow, reason being we don't want OHSS, we don't want multiple pregnancies. So one of the strategies is ultrasound monitoring, okay, and cancellation. Second one, how to stimulate low dose step up, okay, and yeah, essentially this is what it is going to be for OHSS, all right, in PCO. What is used as the trigger? Everybody knows this. For your ovulation, what is used as the trigger? What is the
HC.
trigger given? HCG.
HMG.
Yes. Yeah, good. Somebody said HMG?
No, HCG.
SAG, okay. All right. So the outcomes with this, your gonadotropins is ovulation rates varying between 65 to 70%. How much we had with CC? We had a higher success rate, right? Because those are generally maybe not so resistant cases. So we had almost up to 85, 70 to 85%, and 15% were resistant. Similarly, here, however, it is slightly lower, 65 to 70%. Cumulative pregnancy rates of 6 months becomes 50%. Okay, and your if BMI is more than 30, it is associated with a longer conception time and time to respond to the FSH also for stimulation. So we want to reduce the weight here as well. Hmm? All right. Coming to the number of cycles that can be given, this is only mentioned in one of the TOG articles. And what they have said, this is not for, remember, this is not CC, okay? CC only 6. Hmm? However, for when you're stimulating with gonadotropins, they say if it is less than 25 years, then it's up to 6 cycles. And if it is more than 25 years, up to 12 cycles of induction with gonadotropins can be done. Okay, whether it's practically done or not is not, but this is according to BFS, British Fertility Society. If ovulation is proven with all these cycles, okay, you have given FSH, ovulation has now occurred, okay. So initially you tried CC, maybe it didn't work, they were totally resistant. Then you gave your FSH, and then you got your ovulation. Now, despite these facts, somebody doesn't conceive. Now, what is it? Egg was there, sperm was there, tube was open. Nothing explains it. So go for IVF. Okay? Got it? Yes?
Yes, ma'am.
Yes,
Logic
ma'am.
understood? Clear? Very good. Next, we have here briefly about laparoscopic ovarian drilling. The way it is done is 4 punctures are made per ovary, each lasting 4 seconds, and the wattage is up to 40 watt only. So 444, very nice and easy to remember. They made it for us. So that's what we do, and preferably better response is seen in slim women. Okay, those who have a high basal LH or day 8 LH levels are high, and those who are living too far to be monitored or do not want gonadotropins. In that case, please select LOD. Okay, there's virtually no risk of multiple pregnancies or OHSS compared to that of general population. Hmm? If you compare, okay, the response rates between FSH group, okay, why we would choose the FSH before we go for LOD on a typical basis. If we didn't have any of these 4 factors, why are we going for FSH first? Because it has faster time to conception. Within 6 months, you got two-thirds of your people conceiving directly. Now remember that LOD, you just do the procedure, you leave her for 6 months, only 35% of them will conceive. The subsequently they will require some or the other treatment. Okay, half of them will require more treatment, and then they reach this 67%. Two-thirds of them will conceive, but it took longer to conceive. So we want to go for FSH first. Okay? Okay, although FSH is also the injectables are quite expensive, but it's not a surgery and doesn't entail that risk at least. All right. Coming to metformin and PCO, there were multiple stances, but what I have told you for the purpose of answers, that much is enough for you to know. There is no significant benefit of using it alone by itself, okay, or as a first line measure. But although NICE is confusing about this, but you have to remember in CC or CC resistance or if the BMI is high. Okay, remember to choose the combination. All right. Hmm? Next. Any questions so far? My last for PCO. All right. So you have letrozole, which was just given in one of the TOG articles. It doesn't feature as your answer because of the reasons I have told you before. Is because of the teratogenicity, which was potential teratogenicity, not that it was proven in subsequent studies that it is not going to do any harm, but it's not licensed to be the first line. All right, it is used by other agencies, but not in NHS as such for your answers. Okay, practically things might be different, but it's not to be picked in the exam. Okay, am I clear, Dr. Amy Nero, Pallavi? Yeah.
Yes, madam.
Yes, ma'am.
All right. So, advantages of letrozole, though, if you are asked, then it's just that because it is not anti-estrogenic as such, it doesn't affect the endometrium or cervical mucus like clomiphene did. and essentially has higher pregnancy rates because of that and lower multiple pregnancy rates also. Okay, so it does have a lot of benefit compared. Okay, all right. Before we go on to type one, all right. I'll just have a quick glass of water. Okay, and I'll continue. Okay, is that okay for everybody?
Yes, ma'am.
Yeah. Okay, all right, we're back. So, what was WHO category one? And there was a recent talk also on this. You have to know the causes in which may be asked in your exams per se directly or indirectly in the form of your scenarios. You would know those who have answered this before or practiced the questions that they are not very straightforward in the exams. Okay, and they will give you some or the other, like you have to read the question really well in order to catch the twist in it. So in WHO type 1, it is not a blanket directly go for GnRH analogs or directly go for your gonadotropin pulsatile gonadotropins or uh, GnRH, or to go for your combination of FSH and LH, or to go singly for FSH. All these options will be there and it will get a lot confusing for you. So what we will do is we'll go cause wise, okay, because the TOG does give us separately as well, and it has been tested prior to that also. Okay, now what is the basic concept? How is it divided? How is type 1 and ovulation divided? Can somebody tell me? What are three categories? Come on. Even if you're wrong, it's fine. Dr. Amy.
Type 1 is hypogonadotrophic hypogonadism.
Okay, yes, it's divided into three.
Yes.
Okay.
Type 2 is normal gonadotrophic normal gonadism. And type 3 is
No, I meant to say type 1 and ovulation is divided into three. Yeah, besides the WHO categorization, WHO 1 is again divided into three. So you have to know it is HH, HA, okay, and HB. All right, okay. So HH is hypogonadotropic hypogonadism. What does this mean? Meaning you have you have non-functioning hypothalamus or pituitary, okay, that is HH. All right, it never worked, or it's secondary to something, it has stopped working, so that is HH, hypogonadotropic hypogonadism. And then you have hypothalamic amenorrhea, which is HA, okay. And lastly, you have hypopituitarism, which is HP. Okay. All right. So, hypogonadotropic hypogonadism is wherein your GnRH did not come. And the first thing, these categories that I'm having here right now, okay, that is what when we are talking about your first category, HH. Okay. All right. Causes of hypothalamic, sorry, here we are. Okay. HH. All right. All of these causes which I have enumerated here are your GnRH is not there. All right. Somehow connection between the hypothalamus signals the pituitary to produce things is not there, or there can be something which is wrong with the pituitary, which is hypopituitarism, HP, or both are functionally fine but you're still having amenorrhea, so that is hypothalamic amenorrhea. Got it? Got the categorization, everybody? All right. So in the first situation, we don't have GnRH, right? So Kalman syndrome, this is congenital, or this KISS1 or KISS1 are mutations which are there. So essentially, GnRH never got produced. Okay, or we can have infiltration between the stalk, such as hemochromatosis, sarcoidosis, vaginous histiocytosis. Okay, infiltrative or infective disorders, or something like glucocorticoids, narcotics, which suppress your GnRH per se. Okay, so if your GnRH is not there for any reason, it is the first category. Craniopharyngioma, glioma, other tumors, hematomas, etc. Okay, any surgery, chemo, radiotherapy, which can fry your hypothalamus also. Okay. Hmm? So all this will come under HH. Is that clear? All right. So your GNRH is not there. It is the first category, HH. I'll tell you the reason why we are emphasizing, only because your answer will change depending on the cause for the thing. So you have your hypothalamic amenorrhea, which is your pituitary and hypothalamus functionally are fine. So if she gains weight, it's going to work out, right? So you have excessive exercise, eating disorders, nutritional deficiencies, then psychological stress, any other critical illnesses or chronic illnesses like malabsorption, etc. So if these are there, you just have to treat the basic deficiencies, gain weight. Usually 90% will return back to ovulating. The third category, we have hypopituitarism. GnRH is present, okay, but pituitary is not able to produce the FSH LH. Okay, so this is all your type 1. It is not normogonadotropic normogonadism. All are hypogonadotropic. However, the category differs. Alright, so in hypopituitarism, we can have empty sella, or we have aplasia or hypoplasia of the anterior pituitary, or we have genetic syndromes which can be there affecting the pituitary, something like trauma, meningitis, all of this. Some of them are very close to the causes that we have in HH category also, like your histiocytosis, hemochromatosis, thalassemias. Thalassemia is HP per se. But remember, they will confuse you in this category. But say they tell you, okay, woman had secondary amenorrhea after a PPH episode, and then they will say, yeah, she's diagnosed now with Sheehan's. Okay, now I give you option of pulsatile GnRH, okay, FSH, combination, clomiphene citrate letrozole. Your answer is
FSH.
yes, very good. So, because that pituitary is not going to function at all, no matter how much you pump her with a pulsatile GnRH, you're not going to get anywhere. Alright? However, if I give you, see, they will design it is, they will give you pulsatile GnRH, then they'll give you singly FSH, single LH, and clomiphene and letrozole. Okay, one of this. And the question will be something related to your first cause, HH. Okay, so they've given you a brain tumor, suppose, like a pituitary tumor. Okay, your answer, sorry, not a pituitary tumor, one of the specific causes of HH, which are like your Kalman's or something like that. Now, if you have been given that, all right, you know that you have a functional pituitary in this situation, all right, but alone FSH and alone LH are not your correct options there. If you had a combination, you would pick, but if you're not having a combination, you would go for pulsatile GnRH. Got it? Got me so far?
Yes.
Yeah. So that is how your answer will change. This is why you need to know the level at which, even in inside type 1, which one it is. Okay. Now, you have your investigations that you need to do here. I'm going to quickly go over this. If you do an estradiol level, it would typically be low, which would corroborate further. and you can do prolactin, TSH, other values to rule out other causes of anovulation, as we do with PCO. And if, however, you do your enteral follicle count AMH values, you should remember that they do not reflect correctly in hypogonadotropic hypogonadism or hypopituitarism, because the essentially the stimulus for the ovary itself is not there. Okay, so the ovary can be very small, there might not be any follicles there. So if not having AMH-AFC, okay, or having low AMH-AFC, in that situation does not necessarily mean you have low ovarian reserve or ovarian failure. Okay, so it can typically be low in HH and HP. HA, they are kind of normal, or you can say that more reliable in terms of that. All right. Other things you need to do in addition is bone health assessment, which, because of hypoestrogenism, you can have loss of bone mineral density, osteopenia. So you have to do your DEXA scan, and you have to, of course, start them on HRT. Okay, HRT. Hmm? Can someone tell me which is better? Just a by the way question: HRT or COC pills? HRT or COC pill? Hmm? No one. Okay. So this is homework. Find out. Okay. Now, in HA again, we had the same investigations profile that we had. We took a detailed history, and we had excessive exercise, eating disorders, psychological stresses, the causes. So we, even if we did do an ultrasound, we would, as such, find that the ovaries are normal looking, or they could have a polycystic ovarian morphology, which does not make them PCO. Okay, because the follicles are stimulated, at a very, very low level. Many small follicles do tend to develop when you have eating disorders, etc. In about half the cases, in fact, it can be seen. But contrast to PCO, the endometrium will be thin, estrogen levels will be very low, and you will have a negative progesterone challenge test. Okay, so this is how you will differentiate between a PCO as versus that of a hypothalamic amenorrhea, if at all you are confused with that. This has not been asked, but by the way, all right. So the other hormonal test that you would like to do is brain imaging, and your FSH, LH, estradiol. These I have spoken about previously. Okay, so you can have low or inappropriately normal values of these, and AMH again can show wide variations, as I have mentioned before, because the stimulus to the egg development itself is missing. So you can have low, you can have normal. Okay, sometimes depending on the response of the ovaries, you can have it slightly on the higher side in HA as well. Okay, so hypothalamic amenorrhea, you can have PCO or a higher AMH value as well. Hmm? Brain imaging is not routinely indicated unless you have something like headaches, vomiting, visual disturbances, all of these. These can be your hypopituitarism or hypogonadotropic hypogonadism, hypothalamic one, because of those infiltrative disorders that we have seen previously. Okay, so all of these. Sarcoidosis, granulomas, histiocytosis, any of these could be picked up, or you could have space occupying lesions as well. So you want to do a imaging if you have symptoms. Okay, all right. So in the first one, now this I have discussed, so I'm going to go over it faster. Initial management for your first category would be in HA. All right, HA, you want to advise weight gain moderation of the exercise, target BMI minimum before ovulation induction. British Fertility Society says 18.5. Okay, not 19. It says you advise weight gain below 19. Your target should minimum be 18.5 before you go ahead with any sort of like ovulation induction, because below this you have a risk to the fetus of miscarriage, stillbirth, or fetal growth restrictions. Okay, so you try to normalize this thing. If ovulation does not resume with lifestyle measures, then you go for induction. All right. If any of these hypogonadotropisms are detected pre-pubertally, obviously you want to go for puberty induction and add progesterone once breakthrough bleeding occurs. HRT I have already spoken about, but this answer I'm not giving you here. Okay, I'm moving on. Okay. Anybody got to know about HRT versus COC? Yes.
HRT is a better option than COC
What is the advantage specifically?
because we add the estrogen and progesterone in a sequential manner,
No,
and the
advantage.
bone and the
Like
bone
the
density.
outcomes have to be different, no, for the patient. If it were the same, then it would not make a difference. But yes, bone mineral density is
Yeah,
more with
mm,
HRT rather than
HRT,
using COC.
COC.
That's why it is preferred. Okay.
And usually in the young age, when we give the bone mineral density, that matters a lot.
Hmm. Yes.
Yeah.
So yes. All right. So this one, it is part of the TOG article, though not directly subfertility, but bone health management in hypothalamic amenorrhea would be you use transdermal natural estrogen therapy, preferred over oral, okay, and combine cyclical oral progestin. So transdermal estrogen with oral progestin. This is what is more beneficial, okay, and you need to do nutritional, psychological, excessive exercise related, stress related, all of this rehabilitation for younger women who have this. What is not recommended is bisphosphonates, denosumab, or testosterone, leptin, none of this. Okay, this is just not your subfertility directly module, but um, was a part of your WHO type 1 and ovulation. Okay, so now we come to what is that actual pulsatile GnRH we were talking about. So you have physiologically your hypothalamus releasing every 90 minutes one pulse of GnRH. This slowly causes more FSH, LH release. Okay. In your luteal phase, you have this pulse every 3 hours. Okay, and this is naturally occurring. So what this pump does, it is subcutaneously placed, and it is going to release these pulses for you and mimic how your natural release of hormones would be, and will stimulate your pituitary to produce FSH and LH and result in ovulation. That is the fundamental basics to it. Quite expensive, limited availability, so would not be something you pick in exam first. However, if it is the only option, please go for type 1. Okay, just make sure your pituitary is functioning. So if you're given Shehans, never ever this. Okay, in Shehans, no matter how much GnRH you give, pituitary is not there, nothing is going to happen. Okay, so anything directly only specifically concentrated on the pituitary, please don't go for pulsatile GnRH. This, as we spoke about, either HMG, which contains a combination FSH-LH you want, or you want a recombinant FSH-LH combination. Recombinant is much more easier availability now. Okay. As we have said, for your PCO, we still go preferred with low dose step up protocol only. Okay, which you increase first at the 14th day and then every weekly. Okay, so it takes longer, but monofollicular is our goal, right? So when the dominant follicle is anywhere between 16 to 18 millimeters, typically 17 millimeters, we give a HCG trigger which works as like your LH, okay, surge, and will release the egg. Okay, so in indications for this, as I've said before, hypothalamic, you can go for this or this, and then hypopituitarism, combination only. Why combination only? You can't give only FSH. In hypopituitarism, you can't give only FSH. It's not going to work alone by itself. Okay, or you would require like tremendous dosage of it and take a very very long period of time for it to everything else to manifest on its own, right? But in PCO, remember that you can just give FSH, all right? Which is why if you read your NICE guideline very, very carefully, they will say with in gonadotropin therapy, they have said in WHO type 1, give with LH activity. Okay, people tend to read it very quickly and ignore these minor points which are there, so which will confuse you in the exams. So, HCG injections, dose being anywhere between 1500 to 2500 every 3 days, or more commonly, progesterone supplementation is required for WHO category 1. Any other place where you want to give luteal support? Yes, yes.
Post
Commonly,
embryo transfer.
yes, but which of these would you give, or which is acceptable, and are or both options are okay for you? What is the thing? Dr. Prabhati, yes.
Yes, ma'am. We can give in threatened miscarriages also.
No, I meant in subfertility module itself. So remember that when you're doing IVF, okay, and you've done your embryo transfer, progesterone is the luteal support that you would give, okay, up to going up to 8 weeks, okay. However, this we are talking about WHO category 1 ovulation induction. In IVF typically cycle, what NICE says is you cannot give HCG. You can't give HCG for luteal support there at all. Okay. However, this is different. Here you are doing ovulation induction with your gonadotropins. Okay, which is why she doesn't have a functioning hypothalamus or pituitary, so you're giving that FSHLH from outside, right? So once she conceives, again it needs to come from somewhere else, so you can either give it in the form of progesterone supplementation or HCG injections. Otherwise you have miscarriages because of luteal phase defects. Okay, so your progesterone could not stop coming after your pregnancy is achieved. But after IVF embryo transfer, you should not give HCG. There's no benefit of it. Progesterone supplementation, however, up till 8 weeks. Okay, clear?
So,
Yes.
ma'am, in which cases we can give beta LCG every 3 days?
Only if you have done ovulation induction for type 1 WHO category. No
Okay,
other. No other.
okay, okay. Thank you.
All right. So again, as mentioned previously, no growth hormones, no GnRH agonists for WHO Group 1. These are the different protocols, not super important for exams. Okay. I just made a mention. Not very important. Okay. Hypoprolactinemia was another different, altogether different TOG article. But what you should know, if this is the underlying cause of it, then your treatment option is different. Okay. So you're not going to go for ovulation induction. Before that, please see if there is bromocriptine. All right. Bromocriptine would be your choice number one. Okay, not cabergoline, not your quinabolide, none of that, not surgery, okay, not ovulation induction directly, but please treat underlying causes. Please treat thyroid first, please treat prolactin first, okay, bring the weight to normal. After that, you can do your ovulation inductions, all right. So that's the purpose of this particular one. There wasn't much in terms of like what could be asked in this particular talk, okay. However, they have enumerated all of these causes of your hyperprolactinemia. You will see that many of them are very much similar to your other hypergonadotropic hypogonadism. Okay, all right. So that's there. And besides that, you have physiological reasons why the prolactin could be high, and you have different medications or side effect of different medications as well. All right, not from exam perspective, we can skip it, I guess, but you can go through the list at least once for to have a general idea of what causes it. The first step would be confirm hyperprolactinemia with a repeat, just like semen analysis. This is another test that we do repeat again, okay. And you have to be aware of the hook effect, which is wherein a very high levels of prolactin sometimes give you false low levels because they polymerize into different antigen antibody reaction, okay. So and then, what is more important here is to differentiate between disconnection hyperprolinectomia, which is essentially because you are not having your dopamine reaching the pituitary. Okay, you don't have your prolactin reaching the your dopamine reaching the pituitary, but whereby your prolactin secretion by pituitary increases. So that is disconnection. The treatment for that is dopamine agonist, okay, directly. Or you can have a prolactin secreting adenoma. This is a tumor which releases more of prolactin. Now first line treatment remains dopamine agonist, which is bromocriptine, but this can sometimes require surgery, but that is a later point of time. All right, so you can have micro and macroadenomas. Does everybody know what is the difference between macro definition? Mhm.
Micro is more than 10 millimeters, while micro is less than 10 mm.
So these dopamine agonists, which are there, your bromocriptine and your cabergoline, they restore ovulation about 90% of the cases, and pregnancy is also achieved in 80 to 85. So remember that always going to be the first line in treatment if this is the underlying cause. Okay. All right. So very common problem which arises here will be they will ask you which are the ovulation induction method, and then they'll give you a list, and then your option will be with somebody who has hyperprolactinemia. Remember, before jumping to that answer, treat the hyperprolactinemia. Okay, bromocriptine. All right. Okay, so this is done. This is done. All right. Surgical indications, that's it. Again, this is about prolactin. This is all from your, this is like a summation of your TOG for hyperprolactinemia, but that's fine, right? Not many recent questions from it. We go to IVF, which is the second part of our today's topic. Okay, so we use age. This is a very common question in part two. Age is the initial predictor for the overall chance of success through natural conception or with IVF. So, most important factor if somebody asks you, it's going to be age always. Okay, this is provided at the end of your nice guideline, like to Refer for the different age groups, what is the pregnancy, conception rates after 12 cycles versus 24 cycles. But you don't have to memorize this. As discussed before, you should remember the values 80 and 90, right? So, in a general population, you counsel them that about 1800 couples will conceive in 12 cycles, and remaining 50%, okay, 50% of those that are left yet to conceive will conceive in the next 12 cycles, so total 90%. Okay. Now, these tests which are there, they are very, very specific for those individuals who will undergo IVF, okay, ART. So if you're planning ART, then your AFC, AMH, FSH values. Very, very commonly asked. Any of them can be asked, and what they will put is true or false sort of statements. So they will say that AMH value of such and such predicts low response or has higher chances of OHSS. This is the way that it will get asked. All right. So they will say AFC values of this signifies such and such a thing. So this will usually be in the form of an SBA, and you have to pick out the true or the false statement of these. So there's a trick for this. It is 5 squared 25. So if AMH is basically produced by your little follicles. So if little follicles are many in number, so it's like a lot of potential, then you have a high AMH. Similarly, this corresponds. So your follicle count on ultrasound also will be high. So 4 squares are 16, 5 squares are 25. Okay, everybody remembers this?
Yes, ma'am.
Yeah, okay. So AFC, 4 squares are 16, AMH, 5 squares are 25, and FSH values is something you've got to remember. This is other way around. Okay, so if FSH is high, we know that the ovary has failed, right? So it's not working anymore. In fact, the diagnosis of premature ovarian insufficiency is made by high FSH values, two separate occasions, 4 weeks apart, and the value should be more than more than 25. Okay, more than 25, two separate occasions, 4 weeks apart, you have to diagnose POI. Okay, we don't use ovarian volumes or blood flow or inhibin or estradiol as predictors. Only these three tests for IVF and OHSS prediction. Okay, why we want to do this prediction? This is simple. Why are we predicting? What is the interest in these tests? Guys, come on. Hello. Because you want to decide, right? Whether the
Yeah, you want to know. Yeah.
yeah,
You
response will
want to
be
know how the patient is going to respond.
exactly. So, what do you start with? What is the initial dose that you want? Do you want to take any precautions like a low dose or a higher dose, whatever it is? So, you want to start off because of that. You are looking into this, all right? And patient counseling as well, like you want to prognosticate that the induction might work or stimulation might or might not work, so you want to predict that. Again, this table is extremely important. It's simple, but it's extremely important. We spoke about general measures for general couples, okay, where we said that moderate alcohol consumption didn't really affect in males, etc., etc., but this is specific to your ART IVF. Okay, so please remember, prior to ART, BMI advised to remain between 19 to 30, alcohol not more than 1 unit of alcohol per day. Okay, because it will reduce the effectiveness of ART for the woman. And please stop smoking advice in both the partners, and maternal caffeine consumption has to be reduced. So here, in fact, I had mentioned this as there as well, that caffeine no direct effect on general fertility but affects ART outcome. Okay, so remember here. Okay, remember here that now we have a chance of female age. Of course, this is the most important factor, most important, most commonly asked question also, and other factors, which is number of previous treatment cycles, previous pregnancy history. These also will become relevant. Okay, so these are your general measures. IVF, okay, not general fertility, IVF. Okay. Now, this was asked only once in one of the EMQs, okay, not recent, but what does NICE say not to do was the question there. And they gave different, categories or different scenarios in the different age zones as well. So you should know what they recommend in terms of how many cycles can be offered, okay, in funding criteria, and as well as how many embryo transfers can you do, okay. Those two separate questions were there. So you should know that one cycle is one IVF stimulation with or without ICSI, okay, and up till embryo transfer, up till embryo transfer, okay. So one IVF treatment with egg stimulation, egg collection, with or without ICSI you form embryo, and up till embryo transfer is one cycle. Okay. Whereas a cancelled cycle is where egg collection was not undertaken. Okay. Not undertaken because either it was not possible, no eggs developed, or too many eggs developed and you didn't want to, whatever it is. Okay. All right. A cancelled cycle is where egg collection was not undertaken. Hmm? Now, for the purpose of unexplained subfertility, that a couple has tried for 2 years and or 12 cycles of artificial insemination, out of which 6 cycles need to be IUI. All right. After this, depending on your age group that you are doing it in, if they are less than 40 years of age, they are eligible for 3 full cycles. Okay, 3. So anybody who comes to you, 28-year-old, 30-year-old, whatever reason you are doing IVF, you can do 3 cycles full. Now, if she crosses and becomes 40 during that point of time, no further cycles. Okay, that means because beyond 42, you don't fund anything. Okay, no cycles, zero cycles funded. They can go pay on their own, get it done, but that's a different scenario. Between 40 to 42, you can have one cycle, only provided you have never done one before. Doesn't matter whether you did it, by yourself or it was funded by NHS. And if anybody who's like crosses over to become 40 years, so she's had a one cycle, she was 39 and then now she's become 40, she doesn't become eligible because she's already had one. Okay, if you remember, criteria between 40 to 42 is only to have just one more cycle. Okay, so remember that it's pretty simple, not confusing at all. Beyond 42 0, 40 to 42 only one, below that is 3, but moment you cross over, you no further cycles, it's cancelled. Okay, all right. Now, uh, how many MTUs? All right. So this again depends on the age. So if it is less than 37 years of age, and the first cycle you are doing, okay, doesn't matter what quality embryos you are having, whether you had all good quality embryos or not. Generally, you will have good quality embryos. Okay, but if nothing is mentioned, you always do single embryo transfer because you want to prevent multiple pregnancies. Okay, in the 37 to 39 age group, the first or the second cycle, okay, or the second cycle in less than 37 years, If you haven't got a top quality one, okay, then you can consider double. Okay, but if you got top quality, then always remember, if you have any top quality embryos in any age group, any, okay, blanket, any age group, you will do only single embryo transfer. Okay, doesn't matter, don't try to remember the age for that. Okay, even if somebody gives you 40 to 42 and there is top quality embryos, it will still be single embryo transfer because of the next statement that is made in the separately in nice. Okay, all right, but if you do not have this top quality, then the only time that you do single embryo is if she is younger than 37. Okay, beyond that, you would, if you don't have top quality, you consider putting two. Okay, and never more than two, never ever more than two. Okay, every third cycle, whatever the age group or beyond that third cycle, you can consider putting two, but never more than two. Is that clear? Easy to remember?
Yes, ma'am.
Yeah, remember, any top quality dictum, any top quality, don't try to remember age group. You always say single embryo. Okay. If you don't know whether top quality is there or it's mentioned that top quality is not there, if she's young, you try a single embryo. Okay. But in subsequent cycles, again, no top quality, then please go for please consider double embryo, okay, and beyond. And any third cycle, no more than two embryos. Okay, great. Now we go on to, yeah, so these are the other rules which are there. No more than two anytime. And then top quality blastocyst available, single. Then double embryo when you're considering, advise about the risk of multiple pregnancies, obviously. Is there a difference between pregnancy rates when they are fresh versus frozen embryos?
Fresh embryos will have a greater pregnancy rate.
Does from where are you quoting this? Hmm? The live birth and as well as the pregnancy rate after frozen thawed embryos is very similar to that of embryos in natural cycles. This is nice guideline. It also corresponds with your HEFA, okay? Because now we are using not the older technology. What you are talking about is the slow freeze process,
Yeah,
but
yeah.
with vitrification, okay, fast freezing, you don't have that difference anymore. Okay, all right. Good. Anybody wants a break?
Yes, ma'am.
Tired? We'll be finishing
Ma'am,
soon.
can I ask a question, ma'am?
Yeah, sure, ma'am.
Ma'am, if the patient is between 37 to 39 and it is
Hmm?
her third cycle,
Hmm.
still we have to give, and if the embryo quality is good,
Hmm.
still we go for two embryos or we go for one embryo?
No, single.
Single
That's
only.
what I
Okay.
said. First, remember the dictum. Any top quality embryo is there, single.
Okay.
Doesn't
Okay.
matter age group, cycle, nothing. Don't remember that.
Okay.
Okay.
Because here it is written, madam, 40 to 42, consider double embryo transfer. It's
Consider
consider
double.
only. So if it is,
Consider only.
okay.
Yes. Consider
Okay.
only.
Okay.
Okay.
Yeah.
So it
Okay, ma'am.
doesn't. But these dictums you remember first. All right, never
Okay.
more than two. Any top quality available, single. Okay. I know the guideline is, written in such a way that you tend to read it. Even if you read multiple times, it tends to get confusing. So that's a common thing, which
Mm.
is, isn't it? Yeah. So, where were we? Yeah. So the IVF protocol recommendations will be, yeah, pre-treatment oral OCPs. They do not affect the live birth rate. This is just, by the by from your NICE guideline. And there are certain things that NICE recommends to prevent your premature LH surge, which is GnRH agonist or antagonist protocols, which need to be for your down regulation. And you offer GnRH agonists only to women who are low risk for OHSS. This was one of the very important questions in OHSS, in fact, is what is the prevention, how do you prevent OHSS and what protocol do you use? Okay, so you have to remember that there are two kinds of down regulations which are used when you do controlled ovarian stimulation, okay, which is basically you give GnRH agonists or antagonists to completely suppress the intrinsic FSH LH activity going on inside the body. Okay, after that you give FSH, okay, in a manner that you cause many follicles to develop, and then you also want to prevent the LH surge, right? Otherwise the indigenous intrinsic LH will come and your eggs will all get released before you collected them, right? So you want to prevent that. And there were two protocols which is there. One is using an antagonist and one is using an agonist. Remember, antagonist suppresses more completely, whereas agonists they stimulate first and then they suppress. So the OHS's chances with agonist cycles is high. Alright. If the risk of OHSS is there, please use antagonist protocol, and the answer which will be given to you will be avoid agonist cycle and use longer down regulation. This is prevention strategy for OHSS. Is that clear? Okay, clear? Guys, Dr. Kyle, Dr. Amy, Dr. Nero,
Fine.
good? Yeah. So, we were talking about controlled ovarian stimulation, wherein we used urinary or recombinant gonadotropins to stimulate after we have suppressed intrinsic gonadotropin activity. Okay. Now, FSH dose. Now, this depends on your ovarian reserve. That is why we were doing the test. This AMH, AFC, FSH values. Okay, and other factors like your age, BMI, and presence or absence of PCOS. One should never exceed 450 international units per day FSH because it is very very high level here. Okay. Now, NICE does recommend for the purpose of monitoring, okay, to do ultrasound with or without estradiol. But remember, otherwise estradiol was not being used to predict ovulation. Okay, but for monitoring a response, it does say this. The TOG articles deny it. TOG articles say not to use estradiol, but go with NICE because it's a guideline. It's not an article. Okay, so okay. Do you ever do IVF without controlled ovarian stimulation? Like you do go directly and like unstimulated, can you collect the eggs?
No.
No, no, okay, no. Unlike intrauterine insemination, which is always unstimulated, IVF is always stimulated. Okay, IVF is always stimulated because pregnancy rates are much more increased, and you're doing a costly thing. Might as well keep a few eggs and embryos in the bank. Okay, all right. So, no adjuvant therapies to be used, and like your growth hormone, DHEA, and all of that. And triggering ovulation is always done by HCG. We have discussed this, and we have also seen how to monitor and how to prevent OHSS. Okay, follicle flushing only once. Once it has been asked. It was this straightforward statement given as a true or false. Inside, I mean, five options and pick the right one, and the others were all false, so it's okay. All right, so you don't have to remember much about it. You do not do follicular flushing in if there has been more than equal to three follicles, okay, before retrieval, because it kind of causes more pain, okay, doesn't improve your pregnancy outcomes or number of eggs which is retrieved. All right. So if you've got more than three follicles, don't flush at all. Hmm? And luteal phase support, I have already told you. What was it? You offer progesterone for not more than 8 weeks for IVF. Okay, IVF. Do not use HCG in IVF. Whereas if you did ovulation induction, type 1 and ovulation, you used either progesterone more commonly, and other alternative is to use HCG every third day. Okay, right. So we have certain things for oocyte donation, and the reason for where we were using it is WHO category 3, okay, which is premature ovarian insufficiency or failure, gonadal dysgenesis, bilateral oophorectomy, no ovaries at all, and failure again because of chemotherapy or radiation, and certain cases of IVF treatment failure as well. Remember that sperm donation, oocyte donation, these will be your last resort if they do not have, if the person in question or couple in question does not have their own natural gametes. Okay, if they have gametes, even if it is severe oligospermia or any at all possibility of inducing ovulation, then please go for their own gametes. Okay, don't go for donor, because donor is not biologically related. Okay, we go for biological gamete first in ovarian failure, which is type 3, and in like your absolute azoospermia, things like that, then in those cases, that is primary testicular failure, you would go for donated sperm and egg. Okay, otherwise, no. Hmm? All right. Okay, it's not like how
Yes, ma'am.
it's here, like you are worried about the patient's age and then you recommend them that. No, that's not how it goes. Okay, screening for oocyte donors is always with infectious and genetic disorders, and I don't know why that is. Then, okay, coming to cryopreservation for people with cancers, then we have your cryopreservation for sperm and embryos and oocytes for individuals who are going to undergo treatments which can destroy their fertility. Okay, for men and boys and adolescent boys also, we can have give them the chance to preserve sperm if the treatment can destroy their fertility. Okay, and freezing is in cryo vitrification, which is liquid nitrogen. Okay, and for eggs, embryos, also vitrification is done instead of controlled rate freezing. This gives equivalent pregnancy outcomes in frozen as well as fresh. Okay. So initially it is kept for a period of 10 years. Now remember, this is what NICE says, but HIFA has recently changed and upgraded it to up till the age of 55. Okay, so they can preserve it ongoingly up till the age of 55. Every 10 years, you're required to renew the consent for it, okay, but you can preserve it. All right. Okay. So, oocytes can be again preserved conditionally as long as their cancer is not going to get worse. They can undergo the stimulation, because unlike sperm, you can't just have like a sample collected almost immediately after 3 days, right? You need to wait and stimulate the eggs, then you've got to collect them, and the procedure and the treatment itself can cause the cancer condition to get worse, right? So you've got to balance that risk, and sometimes you can go for quicker controlled ovarian stimulation also. So you can use agonist protocol perhaps, and you can use faster, like a step up higher dose perhaps, that can be used for stimulation. Okay. So, yeah. Shall we discuss OHSS in the same breath, or can we do it in another session if you guys are like tired or something? Okay, because beyond this, we just have OHSS, and then we will have a quick session for maybe to discuss some of the TOG articles, right? Okay, what do you guys say? Please, please, please. I need a vote on this. Hello? Hello?
Yes, ma'am.
Yeah, we can we do it another time?
Yeah,
Okay, madam.
no problem.
All right. So I just wanted to know those